All right, good morning and welcome to the Department of Medicine Grand Rounds. Our speaker today is Dr. Marie Pigeyre. Dr. Pigeyre is a clinical scientist and assistant professor in endocrinology. She has completed her medical training in endocrinology at Lille University in France, and she holds a PhD in genetics and epidemiology from that university. She's completed 3 years clinical and research fellowship in lipid and genetics for cardiometabolic disease in the genetics and molecular epidemiology lab at McMaster with Dr. Pigeyre. Her research area of interest is on biomarkers and genetics of type 2 diabetes and its vascular consequences. Her healthcare delivery includes lipid disorder, diabetes, and general endocrinology. She's based here at the Hamilton General and also works at McMaster Medical Centers and provide endocrinology consults. Well, it's not a surprise that Dr. Pigeyre will take us through a very fascinating presentation today on the subtype classification of type 2 diabetes and a march towards more personalized care. Dr. Pigeyre, please go ahead.
Thank you. Thank you very much for the introduction. Good morning, everyone. I'm indeed very pleased to discuss this morning about recent subtype classification of type 2 diabetes to improve personalized care in this field. So I do not have any disclosure. So the outline for this morning, so we will go first to see how we can identify the different subtypes of type 2 diabetes. We will after that see how is the relationship between this type 2 diabetes subtypes and outcomes and diabetes consequence. And we will discuss how moving towards more personalized care in type 2 diabetes. I think you are all familiar with the classic classification of adult-onset diabetes, so including type 1, type 2, and also the latent autoimmune diabetes in adults. And as you know, most of patients with diabetes we meet at the hospital are from type 2 diabetes. But can we do better than this classification? So actually, there has been a Swedish study published in 2018 who asked for this question and conducted analysis in more than 8,000 people from Sweden on this cohort. All these people had newly diagnosed diabetes, and actually they identified 5 subtypes. So how they did that? So they use routine clinical variables, such as GAD antibodies, as we do routinely when a patient is newly diagnosed with diabetes, age at diagnosis, body mass index, glycated hemoglobin, and they also calculated the index of insulin resistance and insulin secretion that use glucose and C-peptide levels. So using these 6 variables, they actually identified 5 clusters. So the cluster 1 was constituted by the patient who had GAD positive. So it was autoimmune diabetes actually. And for the remaining people, so with GAD antibodies negative, they use a cluster approach using 2-step method. So first they estimated the optimal number of clusters based on algorithm, and they after that apply a classic clustering approach called Kamin's method to assign individuals to 2 clusters. And actually the ideal number of cluster in these people without GAD was 4. And after that, so they set up the Kamin clustering to 4. And this Kamin clustering is a validated statistical method that assigns each individual to a fixed number of clusters. So here it was 4, and whose characteristics are not yet known, but are based on a set of specified variables. So again, the specified variable was the one I gave you. So age at diagnosis, BMI, HbA1c at diagnosis, and the index for insulin resistance and insulin sensitivity. And indeed, they identified this distribution. So 17% was in the cluster 2, 15% in cluster 3, 21 in cluster 4, and 39 in cluster 5. And after that, they looked at how these clusters were characterized. And you have in this graph, so 1, 2, 3, 4, 5 is the clusters. And here you have the different variable, baseline variable that were used to define the cluster. So if we look at HbA1c, cluster 2 was the one with a poorly controlled diabetes at baseline. If we look at BMI, for example, cluster 4 was a cluster with the highest BMI. If we look at HI diagnosis, so this one was one of the oldest clusters. And after that, if we look at the two index of insulin, so here it's insulin secretion and here it's for insulin resistance. And we see that the green one was very different and especially was the one with the highest insulin resistance. And the author, based on that, name these different clusters. So obviously, the cluster 1, as mentioned, was the one with GAD antibodies, so was named autoimmune diabetes cluster. The cluster 2, with the one with poorly controlled diabetes, quite low potential of insulin secretion, if you look at here, so was called by the author insulin deficient diabetes cluster. The third one here in green was called insulin resistance based on these variables. The cluster 4, based on BMI, was named the mild obesity related diabetes clusters. And finally, the purple one, probably less specific, except the age of diagnosis was older. They called them mild age-related diabetes. So it's how these 5 subtypes actually were developed. And interestingly, after that, they tested whether each of these clusters was differently associated with diabetes consequences over the time. So they look at the occurrence of chronic kidney disease, microalbuminuria, retinopathy, and coronary events. And what we can see here, so if we look at the green curve is a cluster 3, so insulin-resistant diabetes cluster. And we see that people in this cluster developed more chronic kidney disease, more microalbuminuria, and there was as well some trend to have more coronary events. And if we look at for the retinopathy related consequences, we see that there's some trend for the cluster in blue, and it was the cluster 2 for insulin deficient cluster. So based on that, we can see that assigning people to different clusters seems to show some differences in terms of outcomes related to diabetes. So insulin-resistant cluster more likely to develop kidney disease and maybe coronary events. And here, insulin-deficient cluster more likely to develop retinopathy over the time. And after this very interesting study that was really a cornerstone on this story in 2018, there are many other replication studies. So there was also other population, American, Chinese, and Japanese population who applies the same approach and found similar number of clusters with similar characteristics as baseline. There is also interesting longitudinal study conducted in the German diabetes studies. It's really close to the Swedish study were based on registry of patients with diabetes. And what they found is that there was some, they study other characteristics to define the different clusters, and especially they look at as well the link between liver and diabetes, and they look at how some specific liver index was differently associated across clusters. So again, each color is one cluster, and we see that the green one seems to be very different at baseline during the follow-up and show some progression as well during the time course. And the green one is the insulin-resistant cluster, and we see that in this cluster there was more hepatocellular lipid content at baseline, and also more frequently hepatic fibrosis at 5 years of follow-up in this insulin-resistant cluster. So what are new findings, which also makes sense, I would say, biologically, as you know, insulin resistance is also an important mechanism involved in fatty liver and non-alcoholic fatty liver disease and fibrosis. And they also look at another consequences of diabetes, including neuropathy. So here they look at diabetes, diabetic sensory motor polyneuropathy. And in this situation, we saw that in orange here is a confirmed diagnosis for polyneuropathy. They were more prevalent diabetic sensory motor polyneuropathy in the insulin deficient diabetes clusters compared to the other 4 clusters. So here, and we see the same at 5 years follow-up of the disease. So interestingly, it's also looked like the insulin deficient cluster was not only associated with more retinopathy, but also some observation here to be associated to the development of more neuropathy at baseline, but also during the follow-up. And some other clinical trials also replicated this, this clustering analysis. So 3 well-known clinical trials, DEVOTE, which test insulin degludec versus glargine, LEADER, which is liraglutide, and SUSTAIN-6, which tested semaglutide. So in this studies, they could not really apply exactly the same method that the one described in the Swedish population, because they did not have the GAD antibodies and they did not have the C-peptide. So this clustering approach was based only on BMI, HI diagnosis, and HbA1c, and they were able only to look at cluster 2 for insulin deficient diabetes, cluster 3 for insulin resistance, cluster 4 for mild obesity related diabetes, and cluster 5 for mild age-related diabetes. And here you see, interestingly, that the occurrence of MACE was higher in cluster 2. And we see as well for nephropathy was higher in cluster 2, which was also consistent with the previous observation done in the Swedish population. So here, highest incidence cardiovascular and nephropathy in cluster insulin resistant. And after that, we also, there is also another study looking at the relationship between glucose-lowering therapy and the different cluster. So this has been conducted in ADOPT that follow the effect of metformin, sulfonylureas, and thiazolidinediones. And what we see here, so same, so you have cluster 2, cluster 3, cluster 4, and cluster 5. So if we follow here, for example, for the insulin-resistant cluster, we see that in blue, we see a better benefits on HbA1c, on thiazolidinedione, and that we don't see on metformin and sulfonylurea. And what we see here for cluster 5, it's also a better benefits here in red on sulfonylureas compared to metformin and thiazolidinedione in age-related diabetes cluster. So this study also shows some trend, I would say, to have a better efficiency of specific glucose-lowering therapy across different clusters. And it's also quite logical that a medication known to be to improve insulin sensitivity show more benefits in an insulin-resistant diabetes cluster, and one like sulfonylureas known to stimulate insulin secretion show more efficiency in a cluster that also characterized by poorly insulin secretion at baseline. So this is logical, but it's not yet a way that we decide how prescribing the different therapy for diabetes. So what we did after this study, so it's a study we recently, actually was last month, we recently published in Diabetology. So we replicate the clustering analysis in the Origin biomarker trial. So Origin is a randomized clinical trial that was conducted in 12,000 people with established or newly diagnosed type 2 diabetes. Participants were followed for median of 6.2 years, and this trial investigated the effect of glargine and found that glargine insulin was neutral for cardiovascular events and other serious health outcomes. But in this subset, in this study of 12,000 people, a subset of 7,000 also had biomarker at baseline, and we will discuss that further after that. But so in the biomarker, we included GAD antibodies and C-peptide levels, and BMI, HbA1c, age at diagnosis for diabetes was also a clinical variable collected during this clinical trial. And interestingly as well, that his origin is a multi-ethnic population. And in these 7,000 participants, we had half Europeans and half Latin Americans. So replicating this clustering analysis in this multi-ethnic cohort was also not only to test whether we have different effects of glargine across cluster, but was also to test whether we can replicate this clustering in a multi-ethnic population. And as a note, the C-peptide level was not measured exactly at the same times of glucose level, so we could not calculate the index of OMA, insulin resistance, and insulin secretion. So here in our algorithm, we use only the C-peptide level instead of the 2-OMA index. And we did exactly the same. So the participants with GAD antibodies positive were assigned to cluster 1, severe autoimmune diabetes, and the remaining participants were assigned to the 4 other clusters. And we use a nearest centroid approach to do that. So I will explain what is this method. So actually this method uses the center coordinate of each cluster for age, BMI, HbA1c, and C-peptide that was estimated in the original Swedish study. So indeed, so when we use cluster analysis, we are able to estimate the center of each cluster for each variable used in the model. So and this data were given by the Swedish team directly. So and was standardized. So it's Z-score for HbA1c, BMI, age, and C-peptide. And for each origin participant, we assign the participant to the cluster from which they was the closest. So how it works very practical view. So how can we assign a person to a cluster to which they are the closest? So actually, for example, if you have a female patient with diabetes, newly diagnosed diabetes, the GAD are negative, and you have her BMI and you have her HbA1c at baseline. So we take an example just with these two variables. You have to calculate the Z-score BMI based on the population of reference, if she's European, for example. And you, after that, take the center coordinate for this variable. So if we look at HbA1c and BMI, so you plot this center. So for example, for cluster 2, you see that HbA1c is at 1.8 and BMI 0.24. So cluster 2 will be here, will be plotted here. If you use a coordinate for cluster 3, it will be here. So for you put the coordinate of your patient. So here in our example, BMI was 0.4, HbA1c was 1. And you calculate after that the distance for your patient from each cluster, the 2, the 4, the 3, and the 5. And the patient will be assigned to the closest cluster. So here would be the 3, for example. So here it is how it works. So we did that for every individual of the origin study, and after that we also look at for validation if the different cluster identified to origin was also associated with different disease courses for major adverse cardiovascular event, for retinopathy, and for chronic kidney disease. And we also look at whether the usage of glargine was given different effect on hyperglycemia across the cluster. And we use the mean post-randomization HbA1c above 6.5 to define hyperglycemia in this analysis. So about the distribution, so here you see origin all population, European and Latin American subset. So we see, if we look at that overall the distribution in origin using this centroid approach was the same. So most of the participants were assigned to the mild age-related diabetes cluster. A minimum of participants assigned to the autoimmune diabetes clusters, and after that was 22% to the insulin deficient cluster, 13% to the insulin resistant diabetes cluster, and 22% to the mild obesity related diabetes cluster. So similar to ANDIS and Swedish population. And now if you look at between European and Latin Americans, if we have a difference, so actually we see a trend here for more insulin deficient diabetes patient in the Latin Americans population. But was a trend, was not a strong significantly difference, but was a trend that was still interesting to be observed. And if we look at now the baseline characteristics was quite similar. HI diagnosis was highest in the mild age-related diabetes cluster. BMI, as expected, was highest in the obesity diabetes cluster. HbA1c was highest in the insulin deficient diabetes cluster, and C-peptide level as a marker of insulin resistance was the highest in the insulin resistant diabetes cluster. So very, very consistently replicated here in the multi-ethnic cohort compared to the Swedish population. And if you look at now for each subgroup based on ethnicity, so European and Latin Americans, we see that the baseline characteristics are very similar across ethnic groups, so no difference here. And now if we look at the occurrence of events for each cluster, so we took was the same method used in the previous Swedish study. So we use mild age-related diabetes as a reference cluster. So the hazard ratio was calculated based on this reference cluster. And we see for coronary events that we have a nominal association with higher risk of developing coronary event here in the insulin-resistant diabetes cluster. What was nominal because if we tested 6 outcomes in total, so it does not really survive to the multiple hypothesis testing, but was still interesting to be observed. No specific difference for stroke, and also a trend for having higher retinopathy in the insulin deficient diabetes cluster. So again, very consistent to what was observed in the Swedish population and in the subsequent clinical trials as well. And now if we look at the 3 outcomes related to kidney disease, CKD stage 3A, CKD stage 3B, and microalbuminuria, we replicated strongly what was described. So higher risk of developing kidney events in the insulin-resistant diabetes cluster here, and for CK D3A, 3B, and also for microalbuminuria. And this was this p-value survived, after multiple hypothesis testing. So strong observation here and consistent replication. And after that, if we look at how the usage of glargine interact with the cluster assignment on the progression of the HbA1c, and here the odd ratio was presented for hyperglycemia, again defined as HbA1c post-randomization above 6.5. So different color has a different cluster. So we use again mild age-related diabetes as a reference cluster, and glargine group is here. So if you look at how was the p-value for interaction between cluster and allocation of glargine, we see here some strong interaction for the insulin insufficient diabetes cluster. Also an interaction for the mild obesity diabetes cluster, and also interaction for autoimmune diabetes cluster, but not for insulin resistant cluster. And if we look at now the value of the odd ratio, so we see that when adding glargine, we decrease the risk of having hyperglycemia in the autoimmune diabetes cluster, in the insulin deficient diabetes cluster, in the mild obesity diabetes cluster, but not in the insulin-resistant diabetes cluster. And the one who seems to benefit the most because of this strong interaction is for the insulin-deficient diabetes cluster. So you will say that it's obvious that if you give early insulin to a patient that is insulin deficient as dominant profile for his diabetes, it makes sense that he has a better progression of HbA1c and decrease the risk of hyperglycemia. But again, because now we do not really apply this clustering approach in practice, when we start a patient on insulin is not considering this clustering approach. So was again interesting observation, and also interesting that in insulin-resistant diabetes cluster, we don't see any effect, right, on the progression of hyperglycemia. And we also tested the interaction, cluster intervention on the different outcomes, MACE and kidney outcomes and retinopathy. So we did not really see significant interaction, but here definitively the power was probably not sufficient to see something when we look at the outcomes in these different clusters. So what I would like to discuss as well, so it's not our study anymore, so here is just a follow-up study that was done again in ANDIS, but they were interesting as well to see if the replication of the different cluster was consistent across ethnicity. So it was another study after ours, and they also saw similar trends that we saw for Latin Americans, that Iranian people that was living in Sweden and including on this initial cohort were compared to Swedish born in Sweden, and we see that there was more insulin deficient diabetes cluster in people of Iranian origin living in Sweden and including in the ANDIS cohort, and more obesity diabetes related diabetes. So yeah, but the message here was also quite consistent with what we see. Seems to have some more insulin deficient diabetes in people not from a Caucasian origin. And interestingly, they also observed a higher risk of coronary events in people of Iranian origin, and an inverse relationship with CKD, so a lower risk of developing CKD across over the time. So also interesting observation here that it seems to have some specificity of type 2 diabetes subtypes across ethnic groups, and also this confirms that outcomes are quite strongly associated with these subtypes and can differ as well over the time, and differ between ethnic groups. And similar approach has been done here. It's really more recent here, so published last month in Indian people. So similar clustering approach to identify subtypes in Indian people. And they also observed that in young Indian adults having diabetes, so below 45-year-olds, the dominant cluster was the insulin deficient diabetes cluster. So 52% of this Indian population was clusters in the insulin deficient diabetes clusters. And it's really opposite to what we see in young Caucasian people, when the dominant phenotype in young people below 45 was actually the mild obesity diabetes clusters. And the insulin deficient diabetes cluster was represented only half of what was observed in Indian people, only 26. So it's also suggested that, again, ethnicity is quite important in the physiopathology of diabetes, and can also help to better identify different diabetes subtypes. And to go to this transition, there is also additional work to verify whether this was clinical entity for diabetes clustering was corresponded to a specific biological mechanism and background to explain these different subtypes. So here it's a study that has been so very recently published 2 weeks ago in Nature Genetics. So same team, Swedish team, who developed the first clustering study, and they use genetic information to characterize the clusters, and they use a genetic risk score. So in a genetic risk score, you compute the genetic variant associated to a specific trait. So here they look at how the genetic variant associated with insulin secretion into a genetic risk score was associated with different clusters. And here they represented the quintile of genetic risk score in the autoimmune diabetes cluster, insulin deficient cluster, insulin resistant cluster, obesity, and age-related cluster. So this was compared to non-diabetic people, and this was compared to SIRD versus all the 3 other clusters. And if you look at here the genetic risk score for insulin secretion, so higher genetic risk score will mean better insulin secretion, genetically determined, I will say. So here we see that in the insulin deficient diabetes cluster, it really confirms that the genetic risk score for insulin secretion is lower across the quintile. The trend in the mild obesity cluster, also a trend in the mild age-related diabetes cluster, but absolutely not in the insulin-resistant diabetes cluster. And here it's an autoimmune diabetes, so it's another physiopathology that is not definitively not capturing here in the genetic risk score for insulin secretion. So and this confirms, right, that the insulin deficient cluster is really based on clinical variable, capture a specific biological mechanism really relevant and consistent to a problem with insulin secretion as a dominant profile for the patient. And they did the same with the insulin sensitivity genetic risk score. So here, it's not the same genetic variant used, but same method. So they use the genetic variant associated that insulin sensitivity, and higher the genetic risk score is, higher the insulin sensitivity is. And we see, as expected, that in the insulin-resistant diabetes cluster, we have lower genetic risk score, and we see this trend as well in the obesity diabetes related cluster. So this genetic information also strongly confirm some biological mechanism underlying the different clusters. So to go back to what we do and what we also look at in origin. So we, as I mentioned previously, our clustering work is conducted in the origin biomarker study, and participants, the 7,000 participants we discussed already had, as mentioned, GAD and C-peptide, but they also had more than 200 blood biomarkers that were measured using a multiplex Luminex platform, and it included metabolic and cardiovascular disease-related biomarker, and that were collected at baseline. And we try to identify whether there was a specific biomarker signature for each cluster, and to do that we use forward logistic regression model applied to each cluster, so insulin deficient, insulin resistance, obesity, and age-related diabetes subtype. And what did we find with that? So indeed, we have been able to identify very specific biomarker. So for example, if we want to differentiate insulin deficient cluster versus age-related diabetes cluster, this biomarker was significantly associated. When we wanted to differentiate insulin-resistant diabetes cluster versus age-related diabetes cluster, these three biomarkers were top signals. So leptin, insulin-like growth factor binding protein 1, and adrenomedulin. And also, for example, when we wanted to differentiate insulin-resistant diabetes cluster versus obesity diabetes cluster, because they are clinically quite close, right? So we identified prostacyclin and adrenomedulin as top signal here. And how does this concentration look like? So if we look at leptin, leptin concentration was the highest in the insulin-resistant diabetes cluster, followed by the obesity diabetes cluster. IGF-BP1 was lowest in the insulin-resistant diabetes clusters, really compared to MIRD and SIDD were much higher. And adrenomedulin was also the highest for the insulin-resistant diabetes cluster. If we look at NCAM now, what we see mostly was here highest in the insulin-deficient diabetes clusters, and what we see for prostacyclin was the highest in the insulin-resistant diabetes cluster. So it looks like this biomarker concentration are quite different across these clusters. So this validated well our forward logistic regression model. And after that, we combine this set of 5 biomarkers into a set of biomarkers and estimated the diagnosis performance of using these 5 biomarkers to distinguish between clusters. And if you want to distinguish, so it's without any clinical variable, so it's only the 5 biomarkers. So if you look at how you can distinguish insulin-resistant diabetes cluster versus the others, you have a quite good performance at 0.83 for the ROC AUC to distinguish the insulin-resistant diabetes clusters. Is less efficient for the obesity diabetes cluster, but still acceptable. So we are using the 5, of course, same biomarker here. But it's definitively less good for the insulin-deficient diabetes cluster and also for the age-related diabetes cluster that are just below the acceptable range. But here it's give us some information that there is a real biological background behind this subtype that can be captured by genetic or biomarker circulating proteins. And also that this biomarker, even is a very short set of only 5 biomarkers, can help to improve the subtyping of diabetes. So, this biomarker were of high relevance from a biological perspective. So, you know that leptin is an adipokine secreted by adipose tissue, highly associated with diabetes and insulin resistance. GFBP1 is a protein also well known to be associated to insulin secretion and is like mirroring insulin sensitivity and insulin secretion. Adrenomedulin is less known for its association with diabetes, but has been described to be associated with insulin resistance. Prostazine is also well known, so less known, sorry, but also described for its role in hepatic insulin sensitivity. And the neuronal cell adhesion molecule is involved in adhesion and organization of pancreatic isolates. So here, also consistent to what we see in the insulin deficient diabetes cluster. So if we summarize, so a combination of simple clinical markers can identify different type 2 diabetes subtypes. And again, was simple clinical marker, BMI, HI diagnosis, HbA1c diagnosis, and for some study, but not all, they use also C-peptide and OMA index. We see that this concept initially developed in a Swedish cohort has been well replicated in different populations and different ethnicity. And what we saw in origin and our other studies, so cluster 3 was really the highest, the one with the highest risk of CKD and possibly MI. Cluster 1 to 4 for insulin deficient diabetes cluster was the one that may have a better glycemic response to insulin. And the natural question is also now to investigate response to other glucose-lowering therapy more recently developed and see if we have differences across study and differences across cluster and outcomes. And as I mentioned, so but based on genetic and biomarker information, it's really suggestive that there is a real biological mechanism that underlines this different subtype, and the future is maybe to identify and use a short set of biomarker to subtype diabetes, and it's what we are now developing in origin. However, you know, there is definitely some limitation to apply that in practice, because the clinical marker we use are really key to determine the cluster. And if we use other marker, we will find other subtype of diabetes that can maybe not overlap. So it's still, you know, to be challenged. And the name we give to the different cluster has been arbitrary. So really given by the Swedish research team. But it's good because we see that is underlying now a biology, but at the beginning was not, you know, completely evident. And what has been also discussed is that this variable BMI, HbA1c can change day to day, and it means that the patient can be assigned to a different cluster if we take this value at a different day. And it has been tested how the clusters are reproducible over the time, and indeed is not 100%. So the most reproducible cluster over the time as autoimmune, because it's based on antibodies, and they can become negative, but 82% was consistent, and the age-related diabetes was also consistent. But the reproducibility of the 3 other over the time was quite low for the insulin deficient cluster. And you see here the trajectory of patients that change from one cluster to another one when we measure the same clinical marker at another time. So very interesting study here. And some other reflection of that is that when we assign a patient to a group, we assume that all the patients in a group are homogeneous for the disease course and the treatment response. And we know that in personalized medicine is not a group response, should be more individualized response. And again, when we assign a patient to the closest cluster, is a predominant clinical profile. So the patient, we gave an example, was closest from cluster 3, but was close as well from cluster 4. So it does not mean that she's only insulin resistant. She can have insulin resistant, but also have some component of obesity related diabetes. So it's still something that is not fully captured in this model, and we could still have some ambiguous situation when one individual is at equivalent distance from two different clusters. And for this reason, there are some other studies that challenge this approach, and rather than assigning a patient to a group, they just follow the individual clinical feature in multivariate models. And the performance of this multivariate model with repeat measure of BMI, HbA1c for each individual perform well as well to anticipate the complication related to diabetes, to anticipate the glycemic progression. And so to give you an example, so they use only age at diagnosis to see how it explains the variation of glycemic progression. And the variation was the same that when assigning patient to cluster. Same for CKD, the baseline glomerular filtration was one of the key variables and was better than the clustering approach. And a multi-variable model using BMI, HbA1c at baseline and repeat measure and C-peptide was better than only assigning the patient to cluster. So still, and it will be my conclusion. So this subtyping of diabetes is definitely a very interesting step to go to a more personalized and precision care in diabetes, but we're definitively only at the beginning of this approach, and it still needs to be probably challenged by some other method that because it's still not perfect. So thank you so much, and I'm happy to answer your question.
Thank you so much, Dr. Pigeyre, for this fascinating approach to hopefully a future of personalized and precision care in diabetes. So as usual, if you have a question, please put it on the Q&A section, and I think we have time for discussion as well. So if you want to raise your hand, we'll bring you in to speak up your questions in person if you wish. There's a question from Dr. Carnot asking us if there's any way to, any of these clusters would predict the benefit of weight loss in diabetes control.
So it's a great question. So this question has not been studied yet, but it's something that can be done exactly in clinical trial, and it's something that we could even look at in origin. But no study done on that question yet. Okay,
I'm going to ask a probably not. Answer will not be clear, but how far are we from a sort of like a new subtypes of diabetes, and how far are we from personalized precision care in diabetes? Since you know these clusters, we know what works for them.
Yeah, I will say the next step will be when updating the guidelines to start accounting for this approach. So we because now we have a large panel of glucose-lowering therapy, so we have now some more personalized approach, for example, prescribing likely SGLT2 inhibitors for kidney outcomes, likely GLP-1 receptor agonists for cardiovascular outcomes benefits. So it's also based on this patient. If we think that our patient not likely to have kidney problems, we'll go more for SGLT2, for example. And so we start to have this new approach for the guidelines, but we still need more evidence for clinical trials. So I know there are other clinical trials being reanalyzed using this clustering approach to see the results on outcome based on that. And this should be, with more evidence accumulated, help to update better guidelines and narrowing, the group of patients that have to benefit from a specific drug for sure. Yeah, but we still have to work on that. And again, is one approach, and maybe we will have to develop even a better one, right? So, but yeah.
Is there anything for a clinician right now to do using this knowledge in terms of deciding which drug to start next or to add next, or maybe moving earlier to insulin? I know that there's a lot of discussion around that. So using this knowledge today, is there anything a clinician can do today for the change in the guidelines and more clinical trials?
So from a clinical practice, so I think what we do today, systematically measure GAD antibodies and having an idea of C-peptide level at baseline is still very useful. Intuitively, when we have high HbA1c at baseline and low C-peptide, we will start insulin early. We will not waste too much time with oral glycemic agent. So it's also that I think intuitively we already apply it, just because we do not have evidence that has been clearly produced. But yes, it's on its way, I will say already. But maybe what is more difficult is between obesity and insulin-resistant diabetes cluster, sometimes more challenging to see if a dominant profile is insulin resistance or insulin deficiency in this patient. But the follow-up and the response to therapy will give the introduction of insulin or any other agent. Yeah.
That's very, very interesting. I don't see any more questions in the Q&A or anyone raise their hand. So thank you so much, Marie, for this fantastic.
You're welcome. Thank you.
And we'll give people 5 minutes back this morning, and I wish everyone a great day. Thank you very much.
Thank you. Thank you so much. Bye-bye.